Welcome to the weekly Neurology Deep Dive, produced by Amer Govanini. Today, we're really getting into something important: the clinical utility of neurofilament light chain assays in managing multiple sclerosis. We're drawing heavily from that recent paper by Orr and colleagues in neurology, neuroimmunology, and neuroinflammation. Now, just a quick reminder before we start this deep dive is purely for educational purposes. There's no commercial goal here. Think of it as a summary of the research. We absolutely recommend you go read the full paper for all the details. All right, for those of you needing the quick version right now, here's the main takeaway. Blood-based neurofilament light chain, NFL, it's a really promising biomarker. It seems poised to help us personalize MS management. It shows real potential for predicting disease activity, monitoring how treatments are working, and even spotting that subclinical progression we worry about. Now, there are challenges: standardization, interpreting individual results, but new assays and research are moving fast, especially when we combine NFL with our standard tools and maybe other new markers. We all know multiple sclerosis. It's this chronic, often unpredictable neuroinflammatory and neurodegenerative condition affecting millions. And personalizing treatment is just crucial, isn't it? Right from diagnosis, picking that first therapy, all the way through checking treatment response over time.
Absolutely. And our traditional tools, things like MRI or the Expanded Disability Status Scale, EDSS, they're foundational, no question. But they often have, well, limitations.
Yeah.
Cost, time, subjectivity. Sometimes they just aren't sensitive enough to really capture ongoing CNS injury, which leaves this unmet need,
Yeah.
for better, more accessible biomarkers to help guide us.
And that's exactly where neurofilament light chain NFL comes in. It seems to offer a lot of promise here. So let's unpack what NFL actually is and then maybe talk about how we might use it in the clinic day to day.
Right. So neurofilaments, think of them as part of the internal scaffolding of nerve axons, these neuroaxonal cytoskeletal proteins. They give axon structural support, help maintain the cell. Now, in healthy people, very low levels of the light chain subunit NFL are constantly released into the CSF and blood. It's just normal tissue turnover, kind of a healthy wear and tear.
Okay, so there's a normal baseline, but what else influences these levels, even in healthy individuals? Are there things we need to account for?
Yes, definitely. Several things impact normal NFL levels. Age is a big one. Levels tend to rise in both CSF and blood as people get older, and they become particularly variable, let's say after age 60. Interestingly, some studies show a sort of biphasic pattern, higher levels in infancy and adolescence compared to childhood. And generally, in healthy adults, men tend to have slightly higher NFL levels than women.
And body mass index. I've seen that mentioned too. Is that a significant factor?
It is, yeah, there's a significant link. Plasma NFL actually decreases by about 0.02 picograms per milliliter per unit of BMI in healthy controls. That's even after adjusting for age and sex. So higher BMI generally correlates with lower NFL levels. It's another variable to keep in mind.
So, okay, these normal variations exist, but clinically, we're often interested in the abnormal increases. What's driving those?
Right. Abnormally high NFL almost always points to neuroaxonal damage. You see it elevated across a whole range of neurological conditions, not just MS. Things like dementia, ALS, stroke, even neurological trauma. It's a pretty general marker of neuronal injury.
Okay, but focusing on multiple sclerosis, what's causing the NFL increase there? Is it just inflammation from relapses?
Well, in MS, elevated NFL can come from a couple of sources. It can be from that focal relapse-related inflammation, definitely, but it can also stem from non-relapse processes, things like compartmentalized inflammation or the neurodegenerative aspects underlying progressive disease. The size of the increase, the magnitude, it's usually much higher when it's linked to focal relapse activity. But what's really notable is that we see elevated NFL across the board: clinically isolated syndrome, even pre-symptomatic MS, relaxing forms, secondary progressive, primary progressive, all of them. That wide presence really highlights its potential utility across the whole MS spectrum.
Let's pivot then to the practical side for clinicians. How can NFL act as a prognostic marker? Can it help us predict patient outcomes?
This is one of the most exciting areas. Multiple prospective studies now show that baseline NFL levels can predict both short-term and long-term outcomes. Take the Asclepios Iron 2 trials of fatumomab, for instance. They split patients into high and low serum NFL groups based on the median baseline level. Compared to the low group, those with high baseline serum NFL had more new inflammatory T2 lesions pop up over years 1 and 2. And they also showed a greater annual percentage drop in whole brain volume, thalamic volume, and white matter volume.
That's pretty strong data connecting baseline NFL to both future inflammation and atrophy. Were similar findings seen in other major trials?
Yes, quite consistently. The Phase 2 APLIO study suggested that baseline and time-matched serum NFL were about as good at predicting new gadolinium-enhancing T1 lesions during the study as baseline-enhancing lesions themselves were. And in the big Phase 3 orchestra trials with ocrelizumab, higher baseline NFL predicted worse MRI outcomes and clinical progression. It's 24-week confirmed disability progression on the EDSS. That held true for both relapsing forms of MS and primary progressive MS patients. Also, in the expanded and informed trials, baseline NFL over 30 pgml was tied to significantly more confirmed disability progression. So the finding seems robust across different drugs and patient groups.
That raises a really key question for practice. Can NFL help us pick up on ongoing damage even when our patients seem stable, maybe because their relapses are well controlled on a high-efficacy therapy?
That's exactly right, and it's a critical potential use. Looking again at a subgroup from the ocrelizumab trials, they found that patients whose NFL levels remained persistently high, even after about a year on treatment, had a greater risk of future disease progression. This really suggests that persistently high NFL, even when relapses are suppressed, might be flagging those non-relapsing progressive injury processes, sort of an early warning signal for underlying neurodegeneration.
What about looking even further down the road? Can NFL give us clues about very long-term outcomes?
The long-term data is quite compelling, too. There was the Phase 3 MS Collaborative Research Group trial. It showed that both CSF NFL and serum NFL levels were linked to long-term outcomes, like changes in brain parenchymal fraction over 8 years, and they predicted who would reach an EDSS score of 6 or more by year 8. Serum NFL was even predictive out to year 15. Another prospective cohort study found that patients starting with low serum NFL were over 4 times less likely to hit an EDSS of 4 or more, and over 7 times less likely to develop clinically progressive MS during follow-up. Conversely, those with the highest baseline serum NFL levels worsened faster, about 0.16 EDSS points per year.
That sounds incredibly useful. How about using it more actively for monitoring treatment response?
Well, since NFL reflects neuroaxonal damage, the logic follows that stable, or ideally decreasing levels while on treatment, suggest the therapy is reducing injury. On the flip side, if NFL starts increasing after someone started treatment, that could signal a suboptimal response, maybe prompting a discussion about switching. We do tend to see bigger drops in NFL with the higher efficacy disease-modifying therapies. But it's worth noting, CSF NFL can stay elevated in maybe 10 to 20% of patients, even on these high-efficacy drugs. That might reflect that ongoing non-relapsing progressive component we talked about.
We touched on subclinical progression. Can NFL also pick up more acute subclinical activity, like new lesions that haven't caused symptoms yet?
It seems so, yes. The APLAO study, again, they found patients who developed new subclinical gadolinium-enhancing T1 lesions showed increased serum NFL levels in the month before the MRI picked them up. So that indicates potential for catching that activity early. Although it's fair to say a larger recent study found the serum NFL increase often lags slightly behind the first MRI evidence of an enhancing lesion. So maybe not always predictive, but certainly reflective of recent activity.
And what about those other aspects of MS, like cognition or neuropsychiatric symptoms? Does NFL correlate there?
The picture there is still a bit mixed. Some studies haven't found a clear link between serum NFL and cognitive or neuropsychiatric measures in stable patients. Others do suggest an inverse relationship with cognitive function, offering some support for serum NFL potentially predicting cognitive decline, at least at a group level. We probably need more large-scale, longer-term studies to really clarify that connection for individual patients.
Okay, here's a very practical challenge. Differentiating a true relapse from a pseudo-relapse. Could NFL testing help us there?
This is a really promising practical application, I think. Pseudo-relapses, triggered by things like infection or heat stress, they don't typically involve new active neuroaxonal injury. So finding a normal serum NFL level in someone presenting with worsening symptoms could be quite reassuring. It might help us avoid giving unnecessary steroids or making premature changes to their disease-modifying therapy. It adds an objective piece to that puzzle.
Are there specific situations or patient groups where NFL might be particularly helpful? Maybe family planning or older patients?
Yes, it could be valuable in several contexts. For family planning, serial NFL measurements might help identify a period of disease stability before attempting conception. During pregnancy itself, serum NFL is convenient for monitoring. And it could help distinguish MS relapse symptoms from common pregnancy symptoms, which can overlap quite a bit, or from pseudo-relapses. For older patients, perhaps those stopping treatment due to immunosenescence, NFL might offer a way to monitor for ongoing activity. Though crucially, clinicians need to carefully adjust for those age-related increases and also potential increases due to comorbidities. That interpretation needs care. Now, regarding measurement, NFL can be checked in both cerebrospinal fluid and blood. CSF levels are much higher, maybe 40 times higher, but getting CSF repeatedly just isn't practical for routine clinical monitoring.
Right, so the development of sensitive blood assays is really what's making NFL potentially viable for regular use.
Exactly. These new ultrasensitive blood assays make quantifying NFL rapid, simple, and minimally invasive. Serum NFL seems particularly good for longitudinal testing. Serum samples seem quite stable room temperature, freeze-thaw cycles, they don't seem to need special handling. Serum levels might also be slightly higher than paired plasma samples, possibly due to matrix differences. As of late 2024, there are several commercially available options for serum NFL analysis in the U.S. These include the ELISimple Plex system, the Simoa single-molecule array that got FDA breakthrough device designation back in April 2022, and the Roche Diagnostics Alexios NFL Immunoassay Lab Corp got breakthrough designation for that one in November 2023. Other assays like ADVIA, Centaur Teleca, and Lumipulse G are around in research, and some might become commercially available soon.
That's quite a bit of progress on the assay front, but despite that, what are the major hurdles we still face in actually bringing NFL into routine clinical practice?
There are definitely still challenges. Several things can confound how we interpret NFL. Other neurological conditions, obviously dementia, stroke, TBI, even peripheral neuropathy can raise NFL. And non-neurologic factors, comorbidities, they matter too. A large real-world study found things like diabetes, smoking, and poor kidney function were linked to higher serum NFL in people with MS. While higher BMI, as we mentioned, was linked to lower NFL, the impact of sex seems variable across different MS studies, so lots of confounders.
And what about the actual measurement itself? Are the results consistent if you use different methods or labs?
That's a really key issue right now. There's still a lack of standardization across different measurement methods and assays. This leads to significant variability in the actual serum NFL numbers you get back. We also lack well-established reference ranges and, importantly, diagnostic or prognostic cutoff values that are specific to each assay. One study highlighted this depending on which published reference data they used. The proportion of MS patients classified as having elevated NFL could swing wildly, from under 4% to over 30%. And we haven't really pinned down what constitutes a clinically meaningful change in NFL for an individual. It's probably context dependent. Plus, there's considerable overlap in serum NFL levels between people with MS and healthy controls that makes interpreting a single measurement for one patient quite tricky.
And the usual suspects, costs and access. How are those playing out for NFL?
Well, being an emerging technology, the cost of NFL testing is currently relatively high compared to standard blood work. That can create reimbursement hurdles. And while several assays have that FDA breakthrough designation, none are formally FDA approved yet for specific clinical use in MSP. Access to the analysis instruments can also be a bottleneck. The Simoa assay, for example, currently needs a specialized analyzer platform, though efforts are underway to adapt it to more common lab platforms to, improve that accessibility.
But thinking about cost, there's a potentially a long-term saving angle here too, isn't there?
Absolutely. If routine serum NFL analysis becomes standard, it could potentially offset cost by reducing the need for frequent MRI scans. That could lower the overall cost of care. It might also save costs by helping us identify suboptimal responders earlier so patients don't stay on ineffective and often expensive disease-modifying therapies for too long. It's an investment that could pay off.
So given those hurdles, what needs to happen to improve how we use and interpret NFL in the clinic? What are the pathways forward?
Well, assay standardization is critical. That and establishing context-specific reference values. We know the absolute numbers can differ based on the assay and the biofluid. For example, one study found that while levels over 23 pgml, or a rise over 30% from baseline, correlated with a 5 to 7-fold increase in MRI activity, those cutoffs didn't hold up well in patients over 50. So we really need reference values established across diverse populations, geographically, ethnically diverse.
And it sounds like a single one-off measurement might not be the most reliable way to use it for an individual.
That's generally true. The group-level findings we see in studies don't always translate perfectly to predicting things for individuals, especially with just one measurement. There's just too much individual variability. Ideally, we'd collect baseline and then longitudinal serum NFL levels for our patients. That way, each person essentially becomes their own control. Tracking the trend is likely more powerful.
And if we are tracking longitudinally, what sort of change should make us sit up and take notice? What's considered significant?
Taking into account both biological and analytical variation, the estimated reference change value, the amount of change needed between two measurements to be confident it's real, is somewhere around 23% to 31%. Now, if you don't have a baseline, one approach is to convert the absolute value into a z-score or percentile. This can help correct for factors like age and BMI. The Kool-Aid group built a reference database from over 5,000 healthy people to derive these age and BMI corrected values. In their study, a z-score over 1.5 was linked to a more than threefold increased risk of future disease activity, clinical or radiological, even in patients who seem stable. NDF.
That's a useful approach. What about combining NFL with other biomarkers? Is a panel approach the future here?
That seems very likely. NFL might ultimately be most powerful when used as part of a panel, complementing our clinical exams and imaging. A recent study looked at 24 different fluid biomarkers and found that using combinations up to 6 markers actually gave incremental improvements in predicting MS prognosis. So yes, a multi-marker strategy looks promising.
Are there any specific biomarkers that seem like particularly good partners for NFL right now?
Glial fibrillary acidic protein, GFAP, is definitely a leading candidate. It's released from activated or injured astrocytes. What's interesting is that elevated GFAP seems more strongly linked to disease progression, while NFL, as we've discussed, is perhaps more strongly linked to relapse activity. So measuring both GFAP and NFL together might give us a more complete picture of both the inflammatory and the progressive subclinical processes in both relapsing and non-relapsing. Chitinase 3, like protein 1, is another astrocytic marker linked to progression, but serum levels often don't differ much from controls, so that one might still require CSF analysis more often.
This has been a fascinating deep dive. It really highlights how blood biomarkers like NFL are starting to, or have the potential to, really change how we manage MS. And the development of these sensitive blood assays has been key to making serum NFL testing more convenient and accessible.
Definitely. As these commercial assays get better, become more standardized, and as we get data from large multi-center studies defining reference ranges and cutoffs for diverse groups, serum NFL measurements may be alone, maybe in combination with markers like GFAP, look increasingly set for integration into routine practice. The goal here is really moving towards more personalized precision medicine for our MS patients.
Let's just quickly reiterate that core takeaway for everyone listening. NFL is a powerful biomarker, still evolving, but with huge potential for personalizing MS care. It can help predict activity and progression, monitor treatment, reveal subclinical changes. Yes, challenges remain standardization, individual interpretation. But the progress in assays and the idea of combining biomarkers suggest NFL is becoming an increasingly valuable tool for your clinic.
And beyond just managing individual patients day to day, NFL could also be really instrumental in clinical trial design. For instance, using it to stratify patients, maybe those with non-relapsing progressive MS, for trials of high-efficacy therapies. So it has a broader impact too, potentially helping us advance MS therapies overall, not just refine care for the patients we see now.
When we combine serum NFL measurement with our traditional clinical skills, our imaging, and potentially these other biomarkers, it really does promise to significantly improve patient care, especially perhaps for those who face barriers accessing frequent MRIs or specialist visits. It pushes us towards a more proactive, data-driven approach. What new insights might NFL unlock for your patients in the coming years? Something to consider. We hope this deep dive into neurofilament light chain has provided valuable insights for your practice. Join us next time for another weekly neurology deep dive, produced by Amer Gavanini.